Everything is good on your side? Tout est bon?
Voilà, it's okay.
On peut y aller?
I think we can start.
Okay, so yes, it's 6 o'clock. Hello everyone, I'm Bernard Lallemand. I'm orthopedic surgeon at Dixbone. I would like to thank you for attending our ninth live broadcast for Dixbone Forum. As you know now, this forum are done to maintain our education platform interaction with our colleagues, surgeon, physiotherapist, sports physician, nurse, and even our patient. This will be available to revisit at any time at our Dixbone channel. So please subscribe by pressing the button below for the support and any new featured video. In our ninth live forum, I'm happy to introduce my colleague, friends, Dixbone Chief Officer, Dr. Philippe Landreau. He is our senior orthopedic surgeon specialized in knee, shoulder, and sports surgery. He is French with global experience across the world and working in France, Qatar, and now heading our Dixbone Center to drive this project to excellence. I will be moderating this session about the Latarjet. For any question you may ask on the chat thread during and after the presentation, we will do our best to answer you all questions. So Dr. Landreau, you have the microphone and lead us through your presentation.
Dr. Lallemand, mon ami Bernard, thank you for that. I will share my my screen to start the presentation about this Latarjet procedure. Can you see my screen? It's okay?
Yes, I just mute myself.
Good afternoon, everyone. So the topic today for this ninth webinar of the Dixbone live broadcast on YouTube is Latarjet. Probably everyone knows this, the name at least of Latarjet procedure. And I would like to try to convince you that maybe it is not the best of anterior shoulder instability because there are different cases, but at least it's one of the best surgical procedure that we can propose to our patient in front of anterior shoulder instability. First of all, a quick reminder about what is the shoulder joint. You know that it's a special joint because it's the joint who has the greatest range of movement in the body. So it means the most probable and possible instability. So it's a sort of compromise, a nice balance between motion, mobility, and stability. And the shoulder stability is based on different things. First of all, the joint surface. You can see that we represent usually the humeral head and the glenoid like ball and socket joint. And you can see that the surface of the joint is very limited in comparison, for example, to the hip. And this is the reason why the capsulolabral structure with the ligament are absolutely crucial. And everyone knows that there is a labrum attached around the glenoid labrum, on which the ligaments are attached themselves. You know, everyone knows that the three layer of the three ligament, anterior ligament, superior, medial, and anterior inferior, which are very important for the stability of the shoulder. Don't forget the muscle at the tendon concavity compression effect with another thing, which is a negative intra-articular pressure. So it means if there is a sort of empty effect inside the joint, and we surgeons, when we open a joint, we see that there is air going inside. So it means this negative intra-articular pressure is very important as well. So bone and soft tissue. So we can separate the two structures which are in charge of the stability of the shoulder in the soft tissue and bone. So it means when there is a shoulder instability, it's either soft tissue injury or bone injury or both. So what about the soft tissue injury first? You know, everyone, that the Bankart is the basic lesion. which can be a Perthes. Usually people call Perthes and Bankart in the same time, but it's a bit different because in Perthes lesion, the periosteum is intact. The Alpsa lesion, which is actually a Bankart or Perthes lesion, which is an old one with some healing process on the anterior part of the glenoid, and some other lesion that the Hagel lesion, humeral avulsion of the glenohumeral ligament on the humerus, and it can be a capsular injury by itself. When we see the bone injury, then there are two lesions in mirror, the glenoid and the humeral head. It can be a bony Bankart, so it's a fracture of the anterior part of the glenoid, which can be acute, bony Bankart, or progressive erosion, and progressively the anterior edge rim of the glenoid become deficient, and it increases the risk of instability. The other one, on the humeral side, is the fracture impaction of the humeral head. So this is what we call the Hill-Sachs lesion, where there is a compression, fracture compression of the posterior part of the humeral head, and this kind of thing increase even the risk of recurrence after a first dislocation if the Hill-Sachs is important, in the same way than the bony Bankart. So now, if we look at in practice, a 26 years old male, right-handed, recreational rugby player, first episode of right shoulder dislocation 2 years ago, 5 recurrences in abduction external rotation, so typically anterior shoulder instability. He has a full range of motion, but obviously apprehension in external rotation, abduction, and relocation test positive. I believe you know what is the relocation test positive. So all these signs of a typical anterior shoulder instability in a young patient with athlete. So if you look at the X-ray, you can see here already that we have some sign of bone lesion, and I insist always on the X-ray. People say sometimes X-ray are useless, only MRI is interesting. MRI is interesting for the assessment of the soft tissue lesion, but the X-ray are very important, and it's a reference for the postoperative control. You can see here on the left up red arrow that there is a sign of Hill-Sachs. This is not normal to have this shape on the humeral head in internal rotation. And if you look at cautiously, you can see already on this small red arrow down that there is a modification of the anterior part of the glenoid with this small piece, which could be, we can already suspect on this X-ray, a lesion of the anterior glenoid. This is confirmed with the MRI, of course. This is the axial view. You see the Hill-Sachs lesion here, which was one day during the 5 recurrence, this Hill-Sachs lesion was here in the contact with the glenoid. And if you see the posterior glenoid rim, which is well designed here, you see that there is a sort of amputation of the anterior part. So not only a Bankart lesion, but a bone lesion. And this is confirmed by this view on the MRI. You can see here the flattening of this anterior part of the glenoid, and at the same time you can appreciate the Hill-Sachs lesion in another orientation than the axial view. So Hill-Sachs, Bankart, so soft tissue lesion, and bone lesion, which transform this normally round glenoid in a flat anterior. So all sign and all factor to increase the risk of recurrent dislocation. So in front of this kind of instability, what are the different treatments currently in 2020? It can be physiotherapy, but we know that unfortunately the physiotherapy is limited for this important recurrent dislocation, in particular in rugby player, for example. Physiotherapy can be interesting in subluxation or slight anterior shoulder instability. The Bankart repair, so it means Bankart repair is a reattachment of the labrum, of the anterior inferior labrum. This one will be limited in this for this patient because you know that there is a bone lesion. So if you treat only the soft tissue, it will be limited. Even if you add a remplissage, which is a nice technique to fill the gap and fill the Hill-Sachs lesion, we can discuss during the discussion with the question after the presentation. But again, it will be limited because the Bankart will not solve the problem of the anterior glenoid rim lesion. And so for currently, the two kind of surgery that we will propose in general in the world, in the 5 continents, is Edenibinet, which is actually a bone graft on the anterior part, or the Latarjet. And this is the topic today, and this is what I would like to develop with you. Actually, this surgery, I mentioned in my text on the YouTube, that this surgery is a French surgery. Yes, because it was proposed in 1954, so it's a long time ago, by Michel Latarjet, who was a surgeon in Lyon, France, the same country of Gilles Valch, another great shoulder surgeon currently. And he described, Michel Latarjet described a coracoid bone block technique to prevent anterior dislocation, suggesting that the horizontal limb of the coracoid process should be fixed to the anterior inferior margin of the glenoid with a screw. And if you want to have more information about this paper, which was in French, so people who are not talking French, we have some, we struggle a little bit, but if you want to have a better idea, 2 years ago in the GISACOS, Journal of ISACOS, a paper was, a review was written about the previous, the first paper and the publication of Michel Latarjet, and you will see all the detail. And he already described the technique as we do now. We modify a little bit, but the concept is still the same. And actually, it was a series of only 4 patients. We cannot imagine now in 2020 to present a series of 4 Latarjet, of course, but it was the first one in 1954. What is the concept of Latarjet? And I would like to insist, because sometimes people miss this concept and they don't understand the effect of the Latarjet. It's much more than Bankart, and probably this is the reason why the results are a bit superior. This is what we call the triple locking effect, which was, by the way, well developed and explained by Pat and Valch during the last years. The first effect is the sling effect, which is on this axial view I did for you. This is the first one, because actually it's probably the most important, is the fact that we put the coracobiceps through the subscapularis, and it makes a sort of sling effect, and you will understand maybe better on the next image. The bone effect, of course, is important because you increase the surface of the glenoid, so this is one of the concepts as well, and the Bankart effect, because in the same time, of course, you will do a Bankart, you will repair the anterior capsule and the labrum in the same time. This is another view showing the triple locking effect. We pass through the subscapularis, you can see here, bone effect, capsular repair effect, and sling effect. And I would like to show you that on one of my surgery. So you see that before we suture the capsule, you can see that here it's the superior part of the subscapularis, here inferior part of the subscapularis, and you see that the conjoint tendon with the coracoid is going inside, and when there is an external rotation, the conjoint tendon has the sling effect because it pushes down the inferior part of the subscapularis and control the extrusion and the subluxation of the humeral head out of the joint and in an anterior direction. So there are 2 important things to understand this kind of surgery. First of all, the bone-to-bone fixation. So it's important because it allows earlier and more aggressive postoperative rehabilitation. So in the experience of the Latarjet, usually the return to sport activity can be achieved after 3 to 4 months, usually 4 months. It depends on the sport, but the constraint sport, 4 months. The second thing, which is very important, is that the capsule is repaired with the arm in full external rotation. So it means there is no postoperative limitation of motion. You know that when we do a Bankart, when we repair the labrum, we have to keep the humerus in slight internal, or at least to not go over 0 degree of external rotation. So it means it can create a sort of stiffness, and some patient can struggle to recover the external rotation and go back to sport a little bit later. In the Latarjet, if you do the Latarjet correctly, and I insist because probably sometimes it's confusing, the true Latarjet, you have to do the capsule repair in full external rotation, and after the surgery, I let my patient do the external rotation as per the pain. Only the pain is the limitation. So cortical fixation. This is what I told you with the screw. We'll go back like this. And the Bankart effect should be with the arm in external rotation. You can see on this surgical view. So now, and this is the capsule fixation. So now some remark about some modification and probably some confusion and some misunderstanding. Some people know the term of Bristow and even Bristow Latarjet, Latarjet Bristow. Actually, Bristow is a surgery which is quite equivalent, but not strictly the same than the Latarjet. It was in 1958. Actually, Elfed described this technique, and he named it Bristow because it was his mentor name surgery. And at this time, the coracoid process was attached to the glenoid rim with only suture. So they detach a small piece of coracoid and suture it on the glenoid rim. So you can imagine that the result of the Bristow were not so efficient, so high, so good, because the consolidation was not frequent. The Latarjet, it's really a bone-to-bone fixation and consolidation. It's stronger, and it makes a bone-to-bone consolidation like in a fracture. Different modification or evolution happened were proposed during the last year in terms of length of coracoid process harvested, the location, flat standing, congruent art. We can discuss that during the question discussion later, 1 screw, 2 screw, etc. So, a lot of people propose some modification of this surgery. If we talk about the bone, if we talk about the management of the soft tissue, how the capsulotomy was done, we don't have time to go to the detail, but I can answer to the question if needed later on. And of course, this procedure can be done arthroscopically. It's a little bit longer, but the results are anyway the same. So I would like just to show you, I know that the majority of you are maybe not surgeon, but maybe it's interesting to see one time how a Latarjet procedure can be done. So the insertion of the patient is very simple, like you can see here. The incision is a small incision on the deltopectoral approach. So you start from the coracoid process, which is under my left index. And usually the incision is 4 to 5 centimeters. Before yesterday, I did for a lady, a small lady, it was 4 centimeters. A big guy, it's 5 or 6. So it's no need to do that more extensively. This is the space between the deltoid and the pectoris major, which we reclined on the lateral side the cephalic vein. So it's really a deltopectoral approach, a mini deltopectoral approach, but it is a deltopectoral approach. And the concept then is this one. You want to harvest the coracoid process. You leave some millimeter of fibers from the coracoacromial ligament, which is cut here, and you can cut the pectoris minor without any consequence on the strength and the function of the shoulder after this kind of thing. You keep, of course, the conjoint tendon because this is the concept of this surgery. Then you use this special instrument for traction, and you see here the fibers of the conjoint tendon, and here it is the coracoid process that we can dissect progressively. And you see that it's a small incision where we move the window of the incision to avoid the big anterior incision on the shoulder where it's completely useless. You don't have to do this kind of thing. With the modern instrumentation and technique that we use for Latarjet, it's clearly possible to do that with a minimal invasive approach. Then the concept is to harvest the coracoid with an osteotomy, which is done with a small 90-degree saw. We use a saw, and we cut the distal part of the coracoid process with this kind of instrument. So don't forget that the brachial plexus is on the right. It's a right shoulder, but there is no reason to go there. We can protect the brachial plexus very easily if the instruments are always going from medial to lateral, and no aggression, of course. So we progressively free the coracoid process with the electrocautery. So for those who are not comfortable with that, the rotator cuff is just underneath the coracoid process. This is a coracoid process, so 1.5 centimeter. And we will prepare the coracoid process with, in order to have a flat surface, debrided and prepared to allow to go to a good consolidation with the anterior neck, the anterior part of the glenoid neck. So this is a preparation which is done with the saw again. So you will see that we remove the cortex, the inferior cortex of the coracoid. And then some people put 2 screws. I put only 1 screw with a special technique for it has been probably 15 or 20 years I'm doing this kind of thing without any problem. And this is a big advantage. You have less risk of fracture, particularly for the small people and the small coracoid process. So you prepare the hole in through the coracoid process. So it's a bit some surgeon detail, I would say. But one thing which is very important, even if you're not surgeon, you have to understand that it's very important to flush the coracoid process with the anterior glenoid rim and to not overhang, to not put the coracoid process too lateral, because otherwise it will make an impingement with the humeral head, and it's a factor of osteoarthritis in long term. Then we have to pass through the subscapularis muscle and to go to the anterior border of the glenoid to prepare it. I'll go fast because it's all details. So we go through the subscapularis and we progressively open the joint to approach and to visualize the anterior part of the glenoid. This is what we do here. We cut the capsule, and then with a game of a different retractor, we can have a vision, limited vision, because it's a mini-invasive, but it's more than enough because this is exactly what we want. We want just to see the inferior part or inferior half of the glenoid in order to prepare and to put the coracoid graft. So then we will drill. So, you know, we will report the measure that we did on the coracoid process on the glenoid, because this is very important. Some company has developed some specific instrumentation, but if you don't have specific instrumentation, you can use this technique that I use routinely, and then we drill through the coracoid process. So it's literally the procedure of like a fracture. So it means we fix, sorry, went a little bit fast. We like a fracture, and then I will show you we measure, and then we will fix the coracoid process with a screw and a washer. So a 4 millimeter screw, and this screw is never a problem because it's inside the bone. So you have to do it again. Okay, and then the coracoid process will be fixed with the screw. Maybe I missed one. Okay, sorry. Anyway, you saw already the previous video with the fixation of the coracoid with the screw at the beginning of the presentation. This slide is important because this is what I give usually to my patient now. There are 3 phases. The first phase is during the 3 first weeks. The concept is protection and basic range of motion. So the patient will mobilize, will be educated to do external rotation and mobilization of his shoulder to avoid stiffness. So the 3 first weeks are literally to avoid stiffness and to go as they can in external rotation, because I told you that the capsule is fixed in external rotation. The phase 2 between weeks 4 and 8, then we progress in motion with the physiotherapist. So this is really when the physiotherapist starts to work after 3 weeks. Passive range of motion, active assisted range of motion, active range of motion, scapular stabilization, and progressive flexion and external rotation. And the phase 3 is weeks 8 to 12 and more. This is a phase of strengthening with the physiotherapist, of course, but then alone with some exercise which are that the patient learn how to do, and we continue to progress in motion. The return to sport is not allowed before 3 months, and usually it's 4 months. I'm used to do a CT scan at 3 months to evaluate the coracoid graft consolidation. And then if the coracoid is consolidated, there is no reason to restrict the return to sport. And for example, for a football player, a professional football player, 4 months is usually the time when they go back to play without any restriction. So what are the results of this surgery? They are excellent, and we can see this systematic review showing in 10 studies were eligible for inclusion. The rate of recurrent anterior shoulder instability was from 0% to 8%. So people who are not used to read that, they will say, oh, 8% is a lot. Yeah, but if you compare with the Bankart, you will see that the Bankart, because it's a global series, the Bankart has a higher rate of recurrence, particularly if you have bone lesion. And the good to excellent satisfaction rate were more than 90% at the final follow-up. And if you look at the big series, I'm talking about series of surgeons experimented in Latarjet, because it's quite tricky and not difficult, but it needs to be very accurate. You see that the rate of recurrence is less usually than 4%. And usually in my series, for example, in my experience, is 2%. And the majority of people who have done the 100 and 100, they have the same experience. Now, if you compare the Latarjet versus Bankart, a lot of papers have shown that the open Latarjet procedure is more reliable, like this study with Boileau and others, in terms of shoulder stability than arthroscopic Bankart repair. So if we take the global series in general, we can say that, or in general, if you want to know for a patient who have anterior shoulder instability, is it better to do Latarjet versus Bankart in terms of risk of recurrence? Sure, with Latarjet, you have less risk of recurrence than Bankart. It doesn't mean that we have to do Latarjet in all cases, because if you select your patient for only soft tissue injury without bone injury, if they are not a high-level athlete and if they don't have hyperlaxity, because it's another factor which is important, then the Bankart is enough. So I don't do only Latarjet. I do easily Latarjet, I do a lot of Latarjet, but I try to really propose the surgery adapted to the most adapted to the patient. Because don't forget that the Bankart is a true anatomical surgery. So you restore the anatomy. Instead, the Latarjet change the anatomy. So it's very efficient in terms of rate of recurrence and stability of the shoulder, but it changed a little bit the anatomy. And there are some complications, probably more than in Bankart. The recurrence are part of the complication. How the failure can happen? Either a technical issue with a bad fixation on the coracoid process, which is more medial. You can imagine if you put this coracoid process here, the shoulder will be able still to dislocate medially to the coracoid process, or if there is a non-union or a problem in the technique. But it can be hyperlaxity. For example, in this case, the coracoid process was perfectly consolidated in the perfect position, but despite that, the patient had a recurrence because he was hyperlax. Even if we say that the Latarjet is a very good indication when patients are hyperlax, we know that some patients, even if you do a good Latarjet, they will still have a recurrence because their tissue are bad quality or very stretchable. I don't know if we can say that. And this is a big factor of recurrence. Don't forget the fact that some of them, they don't have true recurrence, but there are still an apprehension in 5 to 10% in all technique. We don't find that only for the Latarjet, but all technique of shoulder instability treatment. There are some persistent apprehension, sometimes because it's a slight instability, and sometimes because the people are still scared. They have the memory of all the dislocation, and the role of the physiotherapist for that is very important. There are some potential neurological complications, which actually are rare. The most in danger nerve, I would say, is not the axillary nerve, but the musculocutaneous nerve, because the musculocutaneous nerve enter in the coracoid biceps 4 to 5 centimeters down to the coracoid process. So there is a rule, don't go more than 3 centimeters, and you are safe when you dissect and you prepare the coracoid process with the conjoint tendon. Some bone block resorption and non-union, this is known. We know that it can happen even if the technique was very good. This kind of complication happen usually after a technical problem during the surgery. But this kind of image is very frequent. So it means the proximal part of the coracoid process had a progressive resorption that we can see usually after a few months, like if the body make it disappear because, you know, there is no constraint, no abnormal or normal biomechanical constraint on the coracoid process, and only the distal part of the coracoid process stay in place, and the proximal one progressively resolve. Now, this is a nice discussion that we can have. It doesn't mean that the patients are unstable. They have very good result, but when you do the control with the CT scan, you observe in some cases something like that, and probably there are some research to do in the future to avoid this kind of thing. What about the osteoarthritis, which is the usual discussion in anterior shoulder instability surgery? It's important to understand, despite all what have been pronounced, done, and told during the last year, 20 to 25% of the patient in long term with any technique, they have osteoarthritis. And there is no difference between open Latarjet and open Bankart. Some people say, oh, Latarjet give more osteoarthritis. No, scientifically, there is no difference. But probably the arthroscopic Bankart will give less osteoarthritis, but we still don't have enough follow-up, I would say, long follow-up to answer to this question. One thing which is clear, the big technical mistake is to overhang the coracoid process. In other words, to put the coracoid process too lateral, which make impingement with the humeral head, and can, with this impingement, lead to osteoarthritis in long term. It has been shown by different papers. One more thing, the stiffness and the loss in external rotation, it's 5 to 10 degrees. And it's the same in all technique, minimum, but if the Latarjet technique is performed, as I told you, with the capsular repair in external rotation, there is no more loss of external rotation, and some studies even show better recovery in external rotation than Bankart, because in Bankart you really rely only on the capsule, and with the Latarjet you can do the capsule shift repair only in external rotation, which allow to a good recovery in external rotation, and we already discussed about that. So to summarize, is it the best procedure for anterior shoulder instability? There is no best procedure because the patients are different. I will tell you what I do in my practice now with my experience. If there is only a Bankart lesion without significant ill sacs, there is no reason to not do a Bankart repair, because this is the most anatomic surgery. Now there is a Bankart procedure on the remplissage. We can discuss about that for those who don't know what it is. It's a fixation of the capsule and the infraspinatus in the heel sacs to make the heel sacs extra-articular. This is something which can be proposed when there is only Bankart, no glenoid rim lesion, and the heel sacs. This is a very good indication. But when there is a glenoid bone loss plus heel sacs, it's clear that the Latarjet is the best indication. But to be honest, there is usually a discussion between either Latarjet or Bankart repair plus remplissage when we have this kind of bone lesion. And two more things are very important to make the decision. This is, first of all, the practice of contact sport. And I would say, and this is why I put this arrow in this way, more the patients are practicing contact sport, more I will go to the Latarjet, because this is a more reliable surgery for this kind of contact sport. And same remark in practice with the hyperlaxity, which is something important. And more you do, more you have the conjunction of all these glenoid bone loss, contact sport, and hyperlaxity, more it's preferable to do the Latarjet. And maybe in the future we'll combine Latarjet and remplissage, because remplissage is a more frequent surgery that, and we start to have some experience with this surgical technique. Thank you for your attention.
So, thank you, Philippe, for this beautiful presentation, so clear with your draw. It's always amazing to see that, and the surgery was really perfectly done, and it's always a beautiful thing. The only thing I will say from a part of the surgeon, it's always nice to see how you play with the retractor to see good glenoid, but this is really a surgical point of view. So I have some questions. So the first one is about technical problems. So you discussed that you have three effects, and you discuss about the capsular repair. And we know that some surgeons are not repairing the capsula. And do you think there is a big difference about the stiffness and the risk of recurrence?
Yeah, it's a good question because some surgeons don't repair at all the capsule. And I was doing that in 20 years ago. Actually, I changed my mind because with the education of Gilles Vache, I said, okay, why not to repair the capsule as long as you repair in external rotation? And this is why it's an important fact. I don't think there is a big difference. Currently in the literature, some papers start to be talk about this effect of the capsular repair. And it looks like the capsular repair doesn't change anything based on the study that we have, but we don't have a big study, so it's impossible to answer clearly. But one thing is clear. If you do a capsular repair, don't do in internal rotation. So it's better to not do external capsular repair at all than to do in a bad way with internal rotation, because you will have a restriction of external rotation. You will have a shoulder which will be perfectly stable, but not sure that they will recover correctly and they will go back to play sport because they will be limited in external rotation, which can be a big problem for some sport.
Totally. And you know that now with the arthroscopic repair, with the arthroscopic Latarjet, there is this tendency now to repair the Bankart at the same time than doing the Latarjet. So why we don't do that in open surgery?
Yeah, but this is what I do. I don't do routinely arthroscopic Bankart repair because this technique, mini-invasive, is so fast, 45 minutes and very well standardized. And we know that there are some complications with the arthroscopic Bankart, Latarjet. Actually, it's always the same thing. The surgeons who are doing a lot of arthroscopic Latarjet have less complication than others. I do a lot of Latarjet. I have this sort of experience. I don't want to change for the moment the surgery, which gives me a lot of satisfaction. And I'm an arthroscopic surgeon, but for this 4 or 5 centimeter, my opinion is not, it's not worth it. Okay. No. But I repair the capsule always, but in external rotation. So it means I do exactly the same that when we do arthroscopically.
So then the question, one screws, what not 2 screws, knowing that you don't control the rotation of the bone block with the 1 screw.
Yeah, well, this is what a lot of people are telling. There is no scientific support for that. And because there is no study comparing 1 to 2 screw. I've been using this technique for a long time. And when you do a compression screw fixation with a washer, I do a CT scan for all my patients. And there is no abnormal rotation, then the coracoid process are perfectly aligned and consolidated. So I think it depends what you are talking about. If you use 2 small screw, some company propose a cannulated small screw, yes, you have to use 2 because it's otherwise you will not control and you will not have a true compression. But with this 4 millimeter cancellous screw with a washer, small washer, which is not the risk of impingement with the humer head, we have a big compression. And it's interesting that recently Pascal Boileau proposed the endo button fixation for the coracoid process, and he can get a very good compression of this coracoid process with no modification of the rotation. And one more thing, and particularly in this display in this area where we are working now, the coracoid process sometimes is very small, and if you do 2 screw, you have a risk of fracture. So my message is not to try to convince surgeon. I always say that if you want to use 2 screw, this is not a problem. But if you have sometimes a small coracoid process, don't fight. Don't take the risk of fracture of the coracoid process. Use one with a washer like I'm doing. It works very well.
Totally agree. You discussed about the button that they use for the arthroscopic technique. What do you think the quality of the fixation with the risk of non-union? Because we know that there is a good compression immediately, but with time and with what we can have, like the bone resorption, are you not afraid that we can have a higher risk of non-union?
Apparently, the underbutton give good result, and the experience that I don't have experience with underbutton. I like we like to use where we are comfortable, and when you fix an orthopedic surgeon, if there is one thing that he knows, we don't know a lot, it's how to fix with a screw. And this is something that we can control easily. And in the Latarjet procedure, this is something which is really reproducible, easy to do, and efficient.
The position about the bone graft, you put flat or you put on the side, knowing that the under part, the volar part of the coracoid process is round and is really well adjusted to be the prolongation about the articular surface.
Yeah, Joe De Beer from South Africa proposed this modification, which is clever and elegant. The concept is to use the coracoid not like I show you flat, but in the same orientation and the same shape than the glenoid, so it's allowed to increase more the surface of the coracoid, the glenoid, sorry. This is the big advantage. It's well adapted. The disadvantage, there are different disadvantages. First of all, I don't believe, and some papers show that the bone effect is more important. The conjoint tendon, the sling effect is apparently the most important effect in the Latarjet. So no need to focus on so much on the bone, number one. Number two, there is a risk of fracture, and it happened in their technique, because the coracoid process is flat and sometimes very, very thin. And then you have to pass your screw through in the tangential to this coracoid process, and there is definitely a risk of fracture. Number three, the surface in contact with the glenoid neck is very small in this case, and there is a higher risk. I don't have experience, I didn't do myself, but there is a higher risk of non-union and non-consolidation. If you use the coracoid as flat, you can really prepare very nicely the inferior part of the coracoid process and get a good consolidation in general. So it's nice, it's elegant, but it's far from, there are some disadvantages. We need to have more information about this modification, this technical modification.
I totally agree. And we put a 90 degrees twisting in the conjoint tendon, then we don't know what will give.
Absolutely. We don't know the effect of this.
Skeletal nerve could be more strangulated.
Maybe, yes.
So you discuss about the position of the bone, and you say if it's too lateral, there is a risk of impingement and risk of osteoarthritis. If it's too medial or too slow, there is a higher risk of recurrence. But how far from the border of the articular surface we can accept? Because you show us a medial graft that is more than 5-6 millimeter, what is really a technical error, but could we accept 2-3 millimeter, for example?
Yeah. We can accept 2, even maybe 3 start to be a little bit borderline, it depends on the size of the joint, but 2 millimeter is really the maximum that I accept for my case. So it means I like to have a little bit 1 millimeter to flush, but as if when you flush, the risk is to be, it's better to be more medial than lateral. 1 millimeter is the best. If you measure correctly, you can be accurate by 1 millimeter, but 2 millimeter is the maximum that we can tolerate.
So you discuss about the different technique for the bone loss. You discussed anteriorly, we have these Bankart injuries, we have this bone loss from the glenoid, but what will you do if you have a bone loss anteriorly, but associated with a big Hill-Sachs lesion?
It's a very good question. Yeah, it's a very good question, because traditionally, for the big Hill-Sachs lesion, we say, okay, Latarjet will solve the problem, because as it will increase the diameter, anterior posterior diameter of the glenoid, and with the glenoid conjoint tendon effect, it will stop the heel sacs to engage with anterior part of the glenoid. Probably it's wrong for a big case or severe case with heel sacs. And now with the experience of remplissage, I believe that in some case we should do remplissage plus Latarjet. So it means Latarjet will treat the anterior glenoid bone loss. Latarjet will have the sling effect, so it's a plasty more than the repair, so it will have the sling effect with the subscapularis tendon. But if the heel sacs is too big, particularly if it is off-track heel sacs like Itoy described recently, in this case, I believe that a remplissage, as we have very good result with the remplissage in the same time is probably the best way, particularly if it is a contact sport athlete.
So, and the sequence, how will you do? Because we know when we do a Bankart repair, we should start with the Bankart and then the remplissage. And if you do the Latarjet, you start the same or it doesn't change anything?
No, with the Latarjet plus remplissage, either you do everything with arthroscopy if you do arthroscopically, or you do a mini open. So you do a first arthroscopy with remplissage, which is a fast procedure. You leave the suture on the back, then you do your Latarjet, and you can finally at the end tight the suture and the suture that you did through the infraspinatus.
Perfect. So after 3 months, you do a CT scan always. I do the same to see if the bone block is completely healed. What happens if there is no healing? It change your permission to the athlete to go back to sports activity, or you continue and you let him to go back?
No, probably. I would say probably because I review my more than almost 50 cases done during the last years with CT scan, and it made me quite happy with this technique because I could see that the majority consolidate. I had no non-union, but I had some case where it was partially consolidated. So in this case, partially consolidated, because sometimes you do at 2 months and a half, 3 months. So it means in this case, I wait 3 more months for the return to sport. If I can, if the insurance approve, I do a new CT scan because unfortunately the X-ray is not the best to assess the consolidation. But in the majority of the case, and this is very nice for that, you see a perfect consolidation of the bone. So then you can leave the patient to return to sport with trust because the bone is consolidated, the conjoint tendon is there, it doesn't have to consolidate and to heal, so it means there is no reason to restrict the patient to go back to play.
Okay. And we will discuss a little bit about the complication now. You said sometimes in the CT scan you see there is some resorption of the bone because maybe there is not a good vascularization of all the healing and the application is not perfect at 100%. You don't be afraid using a screw and a washer that there is some protrusion that will touch the head?
Yeah, it's a good question because if there is a total complete resorption of the coracoid process, there is a risk of contact between the humeral head and the metal. I don't think the washer will change anything because the prime will be the screw as well. But in practice, it doesn't work like this because if there is a resorption of or at least a resorption of a part of the coracoid process, if you have the opportunity to do an arthroscopy for this kind of patient, you see actually, you don't see the screw free anterior to the glenoid in general. You see a big scar and soft tissue around the screw, and actually, if there is no instability, there is no risk of impingement. But yes, you are right. In comparison with Bankart, there is more risk of complication as you use hardware. As you use hardware or metal, it's always more dangerous, I would say, and with the risk of complication that if you use a soft tissue, suture, or this kind of thing. This is why clearly in the series, the rate of complication with Latarjet are always more important than the rate of complication at Bankart. But the result, it doesn't mean that it's complication or complication, but if you exclude the recurrence, there is less recurrence in Latarjet than in Bankart. And it shows again that this surgery is quite difficult. I mean, at the beginning, there is a learning curve, definitely, and the risk of complication is higher. And some people, some surgeons have a bad experience with Latarjet because I think they don't know exactly, or they don't have, no, they know, but they don't have enough experience, and they have a higher rate of complication. I read a paper recently. They show in a systematic review 30% of complication. I say, where can we have 30% of complication? But if they wrote the paper, it means it exists. So it means in a non-experimented hands, it can be high, and it can be a problem.
Yeah, but you know, Latarjet is, for me, and as you said, one of the most complicated surgery. Why? Because everything is important, starting the positioning of the patient, and the game you do with this retractor. It could be from the skin incision until the end, could be the hell if you are not really well placed. And you discussed about the recurrence, and you showed this beautiful article about the outcomes at the recurrence from 0%. They are quite lucky, until 8%. In this article, you can really summarize the analysis of the failure, at which time, when was happening the failure, the most time of the failure it is after 2 years, after 5 years, 6 years, and if they analyze the position of the graft at the end.
Alors, this series was a global series, but in general, to answer to your question, the recurrence, and this is something important because we always say that if you want to judge a technique in shoulder instability, don't assess the patient 1 year after the surgery. You need a minimum of 3 years. And now I believe that the serious journal, orthopedic journal, they don't accept a series of patient operated for shoulder instability if it is only 1 year minimum. It means you need to have a minimum 3 or 4 years. So it means the recurrence can happen after 6 months until 5 years. Then some patient can have recurrence in the 10 years after. We see that this kind of patient, but it's less frequent. So the majority of the recurrence are happening during the 2 or 3 first years.
The recurrence is after a new injury, so it's like the first dislocation. So I think
and it's usually in the context of sports. So that when the people go back to sport, really go back to sport, then they are at risk to have a recurrent dislocation. This is why it starts at 6 months until 3 years.
Okay, so we have a question of Thierry, who is actually taking a beautiful time in Toscana. So hello, Thierry. So Thierry asking you, what about remaining going through sensation after Bankart repair in athletes? Are you sending them to rehab or you go for Latarjet?
So the question is after Bankart, if they have
yes, apprehension.
So they don't have recurrence, but they have apprehension.
Yes.
Yeah, so I believe that this kind of thing can be solved in the majority of the case with physiotherapy, with work proprioception, muscle strengthening, and everything. But some of them, it happened. I have seen some Bankart. They didn't have true recurrent dislocation, but they have apprehension. And these patients usually, actually, they have apprehension because they have persistent subluxation. Yeah. So as they have subluxation, in this case, I do a revision, and if it was Bankart, I do a revision with Latarjet.
Perfect. And then I have a question for the next speaker, Dr. Boris Pobraj from Slovenia. Hello, Boris. Yes. And he will ask you a really tricky question. What is your algorithm for revision in case of redislocation after a Latarjet procedure?
This is a good question because it's not easy. First of all, it depends how is the coracoid process. If there is a failure of coracoid process or Latarjet, so it means if there is a fracture of the coracoid process, non-union of the coracoid process, or any bone problem, so it means where we can believe that the failure or the recurrence is due to the fact that the Latarjet doesn't work, in this case, I will do a bone revision, because usually there is a bone problem with Hill-Sachs at least. And then I will do a bone revision using a bone graft. This is what we call Eden Ibinet for people who are not comfortable with that. So I correct what is deficient. So if there is a bone deficiency, again, we have to correct with bone graft or something on the bone. And same thing for the Hill-Sachs. If there is no bone problem, so it means your Latarjet looks perfect, consolidation, so on, there is dislocation, a recurrence. It means usually it's due to hyperlaxity. And if there is hyperlaxity, you have to look at two things. First of all, the capsule. Sometimes we can find a complete distension of the capsule above the coracoid process. And then we have to repair to do a new Bankart and capsular shift. And in all cases for me, remplissage. There is one case that I didn't mention, but this is a mistake. It happens sometimes when there is a coracoid process which is put too low. It happens sometimes it's too distal. Then there is still recurrent dislocation. In this case, either you redo the coracoid process, the Latarjet, it's a bit tricky, but the best is to use iliac crest. So when there is a bone problem, you treat the bone. When there is a soft tissue hyperlaxity, you have to treat the soft tissue.
Perfect, yes. So I have one last question, because about the complication, it's really interesting. You discuss about the muscular cutaneous nerve. I think most of the time it's because the people are not releasing correctly the pec minor. But one thing, and especially when you have long screws, and maybe I'm afraid with this other button, you're not afraid to have some entrapment or irritation of the suprascapularis nerve, so the posterior part of the scapula, because you didn't discuss about this.
Agree. So there are some anatomical study, which are interesting. Recently, they did that. And this is a concern because if you put your screw too medial with a medial orientation, there is a risk to damage the suprascapular nerve in this area, just posterior to the glenoid after the notch. The best way to avoid this kind of thing, and if you look at the anatomy, this is a safe way, is to really be as parallel to the surface of the glenoid that you can. But sometimes it's not so easy, because the glen, you cannot put your screw in the correct way. But it's clear that the big mistake probably in this case is to put, sometimes we see some screw really completely oblique, if you compare with the glen. Usually the screw are 10-20 degree maximum angulated with the surface of the glen. Less is better. Less is better. So you have to stay lateral, because you can never go through the glenoid. I've never seen that in the Latarjet, because due to the approach, it's impossible to put the screw too lateral. So you can be as lateral as you can. So it means perpendicular actually to the coracoid process and the anterior glenoid neck. And in this case, it's quite safe, and you don't have any risk less risk for the suprascapular nerve. It doesn't happen frequently, actually.
No, I think it's more frequent with arthroscopy than with open surgery, because you don't have this vision. Yeah. And if you see the arthroscopic screw, they are more medial posteriorly, effectively. So, Philippe, we will finish. I would like to thank you for this beautiful presentation. Can you do a short take-home message for all the people that are listening to you?
I would say that this French surgery, okay, I'm proud, but it's not because it's French. This Latarjet procedure, which was a little bit considered as a non-routine procedure 15 years ago. I remember when we discussed with the American colleague, even 20 years ago. This Latarjet procedure is a fantastic surgery. It's very nice. It stabilizes perfectly the joint. It allows a recover with motion recover in the best condition, and it's really a fantastic surgery particularly for the athlete and contact athlete. it doesn't mean that this is the only one. And as usual in medicine and surgery, every patient is different. So this is why there is a place for the Bankart plus remplissage, and for the Latarjet. And I think it's important to explain to the patient. Yesterday I did the Latarjet. Before yesterday I did the Latarjet for a patient. I gave her the choice. Actually, it could be a Bankart plus remplissage or Latarjet. She said, no, I want Latarjet because I want to be sure to have the lower percentage of recurrence, and the patient should be informed about that. So talk to your patient and explain to your patient.
Perfect. It's a beautiful take-home message. So we are now at 1 hour of our webinar. So I really thank you, and I will introduce. So next week we will fight to see who is the moderator. You or me to introduce our old colleague, Boris Pobraj, Slovenian shoulder surgery, who will do a beautiful webinar about the biceps. So the upper part of the biceps.
In 2 weeks.
After 2 weeks.
In 2 weeks. Yeah. It will be fantastic because Boris is really an expert in this field, and he knows particularly the bicep pathology. And I'm really excited to, I'm sure you too, to listen to our friend Boris in 2 weeks.
He developed his own technique, so we will discuss about that. It will be really interesting.
It will be great.
So thank you. Bye-bye, Philippe.
Thank you, Bernard. Bye, everyone.